Hello, my name is Genesis Chavarria,
And I'm Karina Aguilar.
and this is our final project for our Therapeutics Intervention course. Before we begin, we would like to give some information about our patient. She is a 34-year-old female professional golfer with a type 2 slap tear of her right shoulder. Her date of injury is February 1st, 2020. Some past history include seasonal allergies and a non-operative slap tear that was treated with conservative treatment. The medication that she takes is ibuprofen and Tylenol. Before she was injured, she participated in activities such as yoga and Pilates twice a week, along with working out. She is a single woman with no children, and she has played golf since she was 12 years old. The mechanism of injury for her slap tear was a chronic overuse, repetitive motion of her swinging as she's hitting the golf ball for her sport. Signs and symptoms include deep aching pain, catching and clicking, decreased shoulder range of motion, pain when lifting heavy stuff overhead, affecting the lead shoulder during end of backswing, pain during external rotation of shoulder, and weakness.
Slap tear type 2, it is figure B, and a slap tear is really just located in the superior labrum anterior posterior lesion that often occurs closer to the attachment of the long head of the bicep tendon. The labrum is a cup-shaped rim of firm that contains a fibrous tissue that acts as a cushion to the socket of the shoulder joint and helps with stabilization of the humeral head. There are different types of slap tear, but type 2 is the one that will be presenting. Of injury, it is most often caused by repetitive overuse of the shoulder or even an acute trauma, due to the tear of the labrum wearing down over time. Athletes involved in repetitive excessive overhead movement or force, or as the shoulder is often positioned in abduction and maximal external rotation, it leads to causing the bicep tendon to get twisted and create a force at the glenoid attachment. During these motions, the humeral head acts as a lever and leads to the tearing of the bicep tendon and labrum cartilage from the glenoid bone in the anterior to posterior direction.
Important concerns and precautions that need to be considered is that if a slap tear lesion goes untreated, it can cause severe dysfunction that can affect her daily living activities. As of right now, our patient is diagnosed with a type 2 slap tear, but it can eventually lead to a buccal handle tear, which will further cause damage to her labrum and her biceps tendon. This is very important because this is affecting her professional career, and we need to think of the best outcomes in order to get our patient back to performance.
The operative technique that we will be doing will be the arthroscopic procedure, which the date of surgery for this patient was May 21st, 2020. This is a common surgery that is used with sutures and surgical implants to reattach the torn labrum down to the shoulder socket. This surgery is only tends to be done considered after failure of a non-surgical treatment lasting greater than 3 months in a patient that tends to be suspected to a slap tear. The steps of it is that they're just going to identify excessive damage of tissue that is going to be removed. Then a small hole is going to be drilled into the glenoid bone where the labrum has torn away from the socket. Then an anchor is going to be placed into this hole, and attached to the anchors is a strong suture. The suture is going to be used to tie the torn labrum against the bone, and additional anchors are placed as needed to secure the torn labrum. The advantages of this surgery is that the procedure is a relatively straightforward. It is really has excellent results due to research that's been conducted. There is about 77 to 88% higher rate to return to sport for overhead and racket sport athletes. Even non-athletes, there's about 70 that are able to return to work without restriction. Operative versus conservative treatment is that for the non-operative, it most often includes non-steroid anti-inflammatory medication or intra-articular corticosteroid injections. And then also, most often, this is seen in patients with type 1 slap tear, but can also be done in slap 2 tears. The rehab focus for this type of non-operative technique is that they focus on core, prescapular stabilization, internal rotation, total arc, rotator cuff strengthening, neuromuscular control, cross-body abduction stretching, posterior shoulder strengthening, and there's most often it does a lot of stretching. The time of a non-operative rehab program is about 16 weeks, but even though that the rehab is being done, there is still a chance of the patient that has to go into further surgery if they continue doing their sports. For an operative rehab plan, after surgery, a patient is on a sling for about 4 weeks, and during the rehab protocol, it is recommended to work on elbow and wrist range of motion and strengthening. Um, Also, they do ice the shoulder after operation to help managing with pain and swelling for about 3 to 5 times in about 10 to 20 minutes. Medication will be prescribed by the doctor. They are restricted to do certain amount of motions, so meaning they're not allowed to do active range of motion of external rotation, extension, abduction, or no bicep contraction by day 1 or post-op 2, week 2. By the end of second phase, active range of motion will begin to work on, and then by third phase, it is recommended to work on strengthening the muscles that surround the shoulder joint and gradually restore the active range of motion. By final phase, they focus on helping the patient to be ready to full athlete activities, and most often an operative program. It takes about 4 to 6 months for the patient to feel that they have completely regained their use of arm, but in some cases it could take from 9 to 12 months to make a full recovery.
Phase 1, inactive phase / inflammation phase for our SLAP tear post-op. This ranges from day 1 through week 6. Our patient will be in a sling for the first 4 weeks post-operation. This is our goal for pain and swelling. The patient will decrease 2 inches out of 8 inches of swelling that will be measured by a tape measure by May 30th of 2020. The modality that we will be using is Game Ready, which will be used with the shoulder sleeve for 15 minutes on the lowest pressure since sutures and stitches may still be healing. Our justification is that it will help decrease the inflammation by utilizing the compressive forces of the sleeve to act as contractions to move blood flow and lymph into and out of the swollen area. By doing so, we will be decreasing the swelling and decrease the pain levels for the patient as well. Our early range of motion goal is the patient will be able to increase active assisted range of motion of shoulder flexion in the scapular plane from 60 to 75 degrees that will be measured with a goniometer by week 5 of post-operation. The first exercise we'll have them do is that the patient will be standing with a T-bar in front of them, and they will grab the stick with both hands and raise both arms using their uninjured arm to help assist the injured area into shoulder flexion. We'll have them do 2 sets of 8 for this exercise. The second exercise we'll have them do is that the patient will be asked to perform Codman's and pendulum, 2 sets of 30 seconds. Our justification for these 2 exercises is that the patient will be able to assist the injured arm into shoulder flexion with the help of the non-injured arm by the use of the T-bar. Codman's and pendulums will be used to assist the injured arm initiate early range of motion for the shoulder.
Our phase 2 active phase early proliferation phase is weeks 7 through 14. Our cardio exercises, a patient will be using Stairmasters for 7 minutes for their warm-up. Our range of motion goal is that the patient will increase active range of motion of shoulder flexion from 160 to 180 that will be measured by a goniometer by week 9. Our joint move is that we're going to do a posterior glide that will be applied in having the patient lie in supine position with the clinician placing their hand closer to the humeral head and going through grade 1 through 2 for 6 to 10 times. Grade 1 is done with a small rapid amplitude oscillation that is done for 30 seconds. Grade 2 is done with a large amplitude oscillation hitting their end range and continuing without hitting their end range again, and will be done for 1 or 2 minutes. We are using these grades to help treat pain and muscle guarding. For our first exercise, they're going to do a wall slide with the foam roll for 2 sets of 8. Exercise 2 would be wall crawls on dry erase board for 2 sets of 12. Our justification for these exercises is that this allows to increase their shoulder flexion by pushing themselves to further motion as they're going through the motion of shoulder flexion. For flexibility, our goal is that the patient will improve their shoulder external rotation from 95 to 105 degrees. That will be measured by a goniometer by week 12. In exercise 1, patient will be taken through reciprocal inhibition by stretching the patient into external rotation and stretch for 15 seconds. Then we'll be asked the patient to do an isometric contraction by pushing their hand towards the floor to an external rotation with holding the contraction for 10 seconds. Then the patient will be taken into a further external rotation and stretch for 15 seconds. This will be repeated for 4 times. Our exercise 2 is an external rotation stretch with a towel placed in patient's hand and pulled down with the clinician's force for 3 sets of 45 seconds. Our justification is that we are stretching the shoulder into external rotation, which will allow the shoulder to improve in this motion. Our early strength goal is that the patient will increase shoulder internal rotation muscle strength from 3 to 4 out of 5 that will be measured with manual muscle testing by week 14. Our cryokinetics is that before the patient begins to do these exercises, they will be asked to ice their shoulder until numb for about 15 to 20 minutes, and again when numbness subsides. Exercise 1 is that the patient will be inside laying with the medicine ball in hand and asked to bring the medicine ball into internal rotation and back to neutral for 3 sets of 10. Exercise 2 is that the patient will utilize a resistant band wall mount to complete internal rotation motions for 3 sets of 10. Our justification for these exercises is that with resistance and weight being applied, it is allowing them to help increase their strength for their internal rotation muscles. For the early proprioception goal is that the patient will be able to hold their shoulder abduction at 90 degrees for 30 seconds. That will be measured by the timer by week 14 of post-op. Exercise 1 is that the patient will be asked to hold the yoga ball against a wall, clinician and tapping it for 30 seconds, and they're going to do 3 sets of those. Exercise 2 is that the patient will be asked to do a single arm plank balance on a Bosu ball for 30 seconds, and they're going to do 3 sets of those. Our justification for this exercise is that with an unstable surface, it is allowing more effort and strength from the patient in order to balance and hold those motions.
This is our phase 3 resistive phase late proliferation phase, weeks 14 through 20. Our cardio that we will be having the patient do is a UVE with light resistance for 10 minutes. Our range of motion and strength goal is that the patient will be able to do full active range of motion of shoulder external rotation as measured by a goniometer by week 15. The first exercise we'll have them do is the patient will be asked to do a diagonal D2 pattern with resistance band and at end range do external rotation of shoulder. We'll have them do 3 sets of 15. Our second exercise is that the patient will be asked to go through a D2 pattern with a body blade with 3 sets of 10. The justification for these two is that the reason we believe that these exercises are both range of motion and strength is that we are trying to improve external rotation of the injured shoulder, and by adding resistance bands and body blade brings in a component of strength. For our strength and proprioception goal, the patient will be able to decrease her errors from 8 to 5 as she is maintaining her balance on a physio ball in a starfish stance with her affected arm balancing as measured by the number of times she falls over, as measured by the clinician's observation within 16 weeks of surgery. The first exercise we'll have the patient do is the patient will be balancing on a physio ball with the upper extremity on the ball with her body on the treatment table. The clinician will tap the ball at the bottom for 45 seconds for 4 sets. For our second exercise, the patient will be in a starfish stance on an RX pad with weight in the opposite hand, and the clinician will tap the weighted hand for 30 seconds for 4 sets. The reason why we believe that this is a strength and proprioception exercises is that the patient will be balancing on unstable surfaces while trying to maintain their position while supporting a form of weight, whether it be body weight or a dumbbell. Also, by the clinician tapping the ball and weight in hand creates another form of instability for the patient. Our functional drill and early plyometric goal is that the patient will be able to increase reps from 15 to 25 in a time period of 1 minute of doing a wood chopper against the wall as measured by a stopwatch by week 19 of post-operation. The first exercise we'll have the patient do is wood choppers with a weighted medicine ball starting from a D2 motion and into the clinician's hand for them to throw the ball back to get the ball to return to the patient's hand. 3 sets of 1 minute, counting how many reps she can accomplish. Our second exercise is that the patient will be facing sideways against the wall. With the physio ball, the patient will be dribbling the ball into the wall with their affected arm, dribbling the ball across their body, and we will be counting the time the ball hits the wall in 45-second time period for 3 sets. We believe that this is a functional drill and plyometric because we are trying to mimic the golf swing motion, and by having the ball leave the patient's hand and come back to their hand represents a plyometric.
Our phase 4 aggressive phase remodeling phase 20 weeks and up, our proprioception balance and strength goal is that patient will be able to increase her reps of push-ups on a wobble board from 5 to 15 without falling over and is measured by a clinician's observation by week 20. Our first exercise is that they're going to do a wobble board balance with hands on the board and balancing to do a push-up. They're going to do 3 sets of 10. And then the second exercise would be that they're going to do side slides on a slide board for 3 sets of 10. Our justification for these exercises is that it is considered proprioception and balance and strength because the exercise that is being done on an unstable surface, which requires a patient to have strength in order to be able to reach their goal and doing a push-up on a wobble board. Our strength and plyometric goal is that patients will be able to increase her reps of clap push-ups from 3 to 10 as measured by the clinician observation by week 24. Exercise 1 is that incline push-up with a clap when she comes up, 3 sets of 10, and then exercise 2 will be dead push-ups. Switch from floor to aerobic steppers, 3 sets of 10. Our justification for these exercises is that it is required strength to do a push-up in an incline setting and is a plyometric because they are doing an explosive motion as they have to do a clap push-up. As the patient goes into a clap push-up, their hands leave the surface. Our functional drill goal is that patients will be able to do 10 golf swings with the golf club in the hand without errors as measured by the number of times they perform a complete swing without dropping the club, losing grip of the club measured by clinician's observation by week 26 of post-op. The first exercise is that patient will hold a T-bar behind their back and go through the motion of a golf swing, and they'll do 3 sets of 10. Exercise 2 is that grip strength exercise with a flex bar in different grips and angle to mimic the grip strength, and they'll do 3 sets of 45 seconds. The justification for these exercises is that it would help the patient in practicing their swing and focus on grip strength in order to be able to perform a complete proper golf swing without errors. Our sport specific and strength goal is that patient will be able to increase the distance of her hit after a golf swing from 100 yards to 195 yards, as measured by the wearable GPS tracker that records the yardage of golf swing by week 26 of post-op. Exercise 1 is that patient will be asked to practice her swing and hitting the ball as far as she can. Exercise 2, the patient will be asked to shoot the ball from different distances to hit the target length. Example, patient needs to reach 15 yards, 30 yards, 20 yards, and etc. Our justification for these exercises to be considered sport specific and strength is that the patient is performing a proper golf swing with the golf club using a golf ball. Also, it is using strength because force has to be transferred through kinetic chain to be able to swing the ball as far as she can.
So here is the rehab protocol that we use for a subtear lesion. It's from the Brigham and Women's Hospital. So, of course, we use the arthroscopic labral tear for our type 2 stop tear. And in this protocol, it details all the precautions that we need to take before we start rehab, and it goes through each phase. So here's phase 1, here's phase 2, phase 3, and phase 4. To conclude our presentation, this is our reference list for the articles and videos and pictures that we use for our presentation. Thank you.
Thank you.